Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about new research into cancer-related fatigue with Dr. Rachel Perry. Dr. Perry is an assistant professor of medicine in endocrinology and of cellular and molecular physiology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
Rachel, maybe we'll start by you telling us a little bit more about yourself and what you do.
Absolutely. So I am a metabolism-trained scientist. So I grew up as a scientist studying metabolism. That is how our bodies use nutrients that we either take in from food or generate in our bodies themselves, and where those nutrients go. And how those nutrients can be used to either fuel tumor growth, which is obviously a problem, or to help our bodies fight tumor growth and recover from having cancer. So as I said, my training was in pure metabolism, just kind of looking at where nutrients go and how they're regulated throughout our body. But when I started my lab in 2018, I was really excited about getting into the intersection between metabolism and cancer, because there's been a lot of interest in cancer metabolism in recent years. And I thought that there was really a place for metabolism-focused scientists to apply the tools and sort of ways that we think about science to really try to make a difference, again, in terms of coming up with metabolism-targeting therapies and potentially dietary and other recommendations for patients who are dealing with cancer.
So let's take a step back. I think when many of us think about metabolism, we think about, kind of diet and exercise and revving up our metabolism to burn off a few extra calories, building muscle that builds your metabolism and that kind of thing. Can you talk a little bit more about what exactly is metabolism and what is the nexus between metabolism and cancer?
Sure. So metabolism is really the study of what's coming in and what's going out as far as nutrition, as far as nutrients. So what comes in boils down to both the foods that we eat as well as what our body does itself. So many people aren't aware that our bodies do quite a bit in terms of generating metabolites. So that is generating nutrients and then using those nutrients in various pathways. And there are a lot of places that we can intervene in that process and change what nutrients our bodies are generating in a way that could potentially be beneficial. And in addition, I mentioned it's the study of what's coming in and what's going out. What's going out is where those nutrients are going. So for instance, if our liver makes glucose, so that's sugar that our liver can make when we haven't had anything to eat in a while, where does that sugar go? Does it go to our muscle? Does it go to our brain? If we have cancer, does it go to our tumor? And how can we intervene to send those nutrients to a place where they're more beneficial, like to our brain or to our heart, as opposed to somewhere where they would cause us a problem, for instance, going to a tumor? And when you ask about the intersection between metabolism and cancer, this is really I wouldn't say an open question, but an area of a lot of active study. So there's been, for the last 100 years, a knowledge that tumors really like glucose. So tumors take sugar, and this fuels tumor growth quite a bit. But what we've learned in recent years through work from our lab as well as many other wonderful labs is that this is a lot more nuanced than simply glucose fuels tumor growth. So number one, there are various nutrients that are fuels for immune cells. We know that our immune cells are quite important in the anti-cancer response. And immune cells like glucose, they like amino acids, and potentially there are additional mechanisms of metabolic regulation of the immune response to cancer. And in addition, it's not just glucose for tumors. So tumors are really good at using whatever metabolites, whatever nutrients we provide to them. And so in my view, being able to intervene effectively in this intersection between metabolism and cancer is really going to require thoughtful approaches that combine metabolic interventions with additional anti-cancer interventions so that we can potentially boost the effectiveness of anti-cancer treatments like chemotherapy and immunotherapy.
When you talk about tumor cells being fed by metabolites like glucose or sugar, this brings up one of the common questions that we get asked, which is, if you've been diagnosed with cancer and cancer feeds on sugar, should you cut out all sugar from your diet in order to starve cancer cells?
Well, I think my first response is that, we can never blame patients for having done the wrong thing from a dietary standpoint or a lifestyle standpoint in any way, because there's no way to predict that one will eventually develop cancer. And in addition, if one were to have cancer and completely cut out sugar, unfortunately, there's no guarantee that will have a beneficial effect on their prognosis. But that said, there is literature that reducing sugar, one doesn't have to cut it out completely, but really reducing sugar and consuming a high protein, high fat diet that is low in sugar may have beneficial effects in a number of types of cancer. This is ongoing research. This isn't a sort of conclusive study yet. But there is quite a bit of evidence from both animal models and also human clinical trials that reducing sugar, lowering the carbohydrates in our diet may have beneficial effects on cancer.
Okay. But just to kind of delve into that just a tad more, because that brings up a couple of other key questions. One is that people will say, I'm going to avoid eating fruits and vegetables, especially fruit, because fruit has sugar. What do you think about that? Many nutritionists will say to cancer patients that they should eat a predominantly plant-based diet with fruits and vegetables. But if fruits have sugar and sugar feeds cancer, isn't that a disconnect?
So that's a great question. And the answer really is that there are different types of sugar. So evidence has shown that the worst type of sugar to consume in general for our health, as well as in cancer, is what's called high fructose corn syrup. And so this is added sugar that's in cereals and cake and cookies and things like that. The sugar that's in and that high fructose corn syrup causes a host of metabolic problems, and it seems to be more efficient at fueling tumor growth than other types of sugars. The sugar that is in fruit is sort of a more quote-unquote natural sugar that has less of a detrimental effect when it comes to fueling cancer growth. But that said, the evidence would suggest that it is absolutely fine to consume sugar and absolutely fine to consume fruit. I didn't mean to say sugar. Absolutely fine to consume fruit, and better to use fruit rather than, for instance, cake if we want to satisfy our sweet tooth. But, it's probably a good idea for cancer patients to try to some degree limit the amount of fruit intake as well, because it does have some degree of sugar that can be broken down and metabolized in a way that could potentially fuel tumor growth. But with all that said, dietary recommendations have to be what we call palatable. They have to be doable for the patient. And so, I think it's much better, per what all the research says, to consume a little bit of fruit amidst a high protein diet that you can actually stick to, rather than, making no dietary modifications at all. And if that fruit makes the diet more palatable, it's absolutely worth it.
And then the final question on this kind of line is, if we're trying to avoid sugar, but we still have a sweet tooth, what is the current thoughts about artificial sweeteners? We've seen that, some organizations have said that artificial sweeteners might actually be carcinogenic. But if sugar also fuels cancer, then isn't that carcinogenic too? And if so, which is worse?
Absolutely. And so, to my knowledge, most, if not all, of the research on artificial sweeteners and cancer has been in vitro. That means in cells in a dish, where in most cases, people are giving very, very high concentrations of the artificial sweeteners. And it turns out that if you give high concentrations of many different chemicals to cells, this can have an effect to promote cancer, again, in a dish. I'm not aware of convincing clinical trials in people that control for other relevant factors. So, for instance, many times people may be shifting to using artificial sweeteners in an attempt to lose weight. So these, for instance, may be people who have obesity at baseline or who have metabolic dysfunction at baseline. And then you sort of can't deconvolve the effects of the artificial sweeteners from the effects of the underlying problems with metabolic health. So personally, I would say if my family or friends ask me for a recommendation, although I'm not a doctor and so I can't give clinical recommendations, but I would say absolutely artificial sweeteners would be expected to be better in terms of, lowering the cancer risk when substituting for sugar as opposed to sugar. And frankly, for myself, that is what I do, using artificial sweeteners rather than sugar.
Phew, because that's what I do too. Full disclosure. So I want to now kind of move into the work in your lab, looking at how you can kind of target these metabolic pathways in terms of cancer. Can you talk a little bit more about your research?
Absolutely. So because of my background in metabolism, we've been applying a number of different metabolism targeting drugs in mouse cancer models and sort of tracing what they do to the response to immunotherapy and chemotherapy and tumor growth by itself. And so there have been several recent studies, one of which was looking at trying to develop a precision medicine approach. So using tumor genetics to predict response and applying a common diabetes drug that's called an SGLT2 inhibitor. And we showed that you can predict which tumors may be more likely to respond to the SGLT2 inhibitor than others based on the tumor genetics. And I think that's very important because a lot of really all of the metabolism targeting human clinical trials that have been done have not been based on tumor genetics. We're using precision medicine for everything else in oncology, not everything else, but almost everything else. And so I think there's really a role for precision medicine metabolic therapy. And with that, there are also sort of unexpected findings that can come out. We had a recent paper that just came out showing a metabolism targeting modality for cancer-related fatigue. And so it's been a lot of fun in recent years to look at what metabolism targeting agents do and how we can use them not only as anti-tumor agents, but also to reduce the complications of cancer itself and cancer therapy.
So we're going to pick up that conversation right after we take a short break for a medical minute. Please stay tuned to learn more about battling cancer-related fatigue with my guest, Dr. Rachel Perry.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where the lung cancer screening program provides screening to those at risk for lung cancer and individualized state-of-the-art evaluation of lung nodules. To learn more, visit smilowcancerhospital.org. The American Cancer Society estimates that nearly 150,000 people in the U.S. will be diagnosed with colorectal cancer this year alone. When detected early, colorectal cancer is easily treated and highly curable, and men and women over the age of 45 should have regular colonoscopies to screen for the disease. Patients with colorectal cancer have more hope than ever before thanks to increased access to advanced therapies and specialized care. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for colorectal cancer. Tumor gene analysis has helped improve management of colorectal cancer by identifying the patients most likely to benefit from chemotherapy and newer targeted agents, resulting in more patient-specific treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anees Chagpar, and I'm joined tonight by my guest, Dr. Rachel Perry. We're discussing the use of a new drug to battle cancer-related fatigue. Now, we really didn't get into the drug itself because right before the break, Rachel was telling us more about some of the work that her lab does in looking at metabolism and cancer. So, Rachel, can you kind of pick up the conversation from where we were? So my understanding is that you're now using more precision genetics and genomics to look at metabolism, both for therapeutics as well as to battle fatigue. So can you talk a little bit more about how exactly that works and what your findings have been?
We had, based on the literature, we had a suspicion that increasing whole body and specifically immune cell glucose metabolism, so sugar metabolism specifically, may improve the response to immunotherapy in cancer. So we thought that by giving a drug to rev up glucose oxidation, so glucose metabolism, that this may improve the response to immunotherapy against melanoma in mouse models, so skin cancer in mouse models. And we treat it with the help of a wonderful graduate student, Xinyi Zhang, who is defending her PhD soon and moving on to the next steps. Xinyi treated a number of mice with melanoma with a drug called dichloroacetate. And I'll refer to it as DCA in this talk because it's much quicker. And so when she treated mice with DCA, we were expecting to see that it would improve the response to immunotherapy, but that did not turn out to be the case. She did studied a number of mice, very careful experiments. It did not improve the response to immunotherapy. But we were very pleasantly surprised and excited to see that there was a phenotype. So DCA made the mice a lot more, quote unquote, perky. The mice, despite having large tumors, moved around their cage. They were, mice will climb the walls of their cage, grab the top of their cage and climb on top of it if they're healthy, but not when they have a large tumor. But these mice treated with DCA, their physical performance was completely preserved, despite having fairly large tumors at this stage. And we thought, we're not mouse behavioralists, but this is a clear effect. And so that really brought us into the world of cancer-related fatigue. It's one of these happy accidents. Sometimes in science, you can do the good science, you can have the good plan, but it may not turn out the way you're expecting, because really, if we already knew the answer, we wouldn't be doing the experiment. And this was one of these wonderful cases where, although the initial result was disappointing, DCA did not slow tumor growth, we ended up having a really exciting finding that DCA could improve cancer-related fatigue in mice.
Part of that makes me wonder if DCA was the idea behind it, and correct me if I've misunderstood, if the idea behind it was to rev up the metabolism so that they would respond better to immunotherapy, it sounds like it revved up their metabolism to, run around their cages, but really didn't rev up their metabolism to respond to the therapy. Why the disconnect?
It's an open question, certainly. And I don't have a conclusive answer. There have been studies using higher doses of DCA that do show beneficial effects. So I think it may be a dosing question. But we sort of come at it from the angle of, it was disappointing that it didn't improve the response to immunotherapy, but if it makes the mice feel better, so down the road, if it makes the patients feel better, that could still be a beneficial effect. And honestly, there is literature from human patients showing that patients who undergo cancer-related fatigue, which is a severe, debilitating fatigue that can't be relieved with sleep, unlike the fatigue that we might feel if we're running a marathon. Having cancer-related fatigue actually reduces the likelihood that patients will fully complete their cancer treatment. There are patients who feel so crummy because of cancer-related fatigue that they actually don't take their treatment to completion. And that, not completing cancer treatment, would obviously be expected to have detrimental effects on cancer outcomes. So I think, although, mice don't get to choose whether or not they complete their cancer treatment, I think down the road, if this were to move to human patients, there is the possibility that there could, in addition to improving quality of life, there could be an effect to improve the sort of treatment success rates in patients.
Yeah, no, absolutely. I think that it's really exciting. Has there been a movement beyond mice?
We would love to do that. There hasn't been yet, but there are some hints that this may be possible. So DCA actually was approved by the FDA for treatment of another condition called lactic acidosis. And this is the buildup of lactate in the blood and can happen for various reasons, not necessarily related to cancer. But actually, in the 1980s, DCA was approved as a treatment for this disease. And that is because DCA pulls carbon, it pulls metabolites from lactate and pyruvate, which exchanges with lactate, into the TCA cycle. And so it essentially depletes the buildup of lactate in the blood and allows the body to oxidize it, so using that fuel rather than allowing it to build up. And so because of that, DCA, as I said, was approved in the 1980s. And so although it's not current treatment in the hospital for lactic acidosis, because we have better therapeutic approaches now, the fact that it was FDA approved indicates that it is safe and it is effective at lowering lactate. And so, at this point, we are talking with colleagues and thinking about potential next steps toward a clinical trial using DCA for cancer-related fatigue, because we already know that it's safe and effective at lowering lactate. And, related to that, a point I do want to make is that at this stage, we really have no pharmaceutical treatments for the entire syndrome of cancer-related fatigue. So, it's at this point, it's treated symptomatically. So inflammation can be treated with NSAIDs, so ibuprofen, drugs like that. If there are mental health symptoms, they can be treated with anti-anxiety or antidepressant medications. We may recommend yoga or, interventions like that. But there really is no drug treatment for the entire syndrome. And we think, based on the mouse findings, that there is the possibility that DCA could potentially represent the first pharmaceutical treatment for the entire cancer-related fatigue syndrome.
So that's really, really exciting. Tell us a little bit more about kind of some of the other work you've been doing as well, looking at things that how can kind of metabolic interventions actually affect effectiveness of treatment as well.
Yeah, absolutely. So, both immune cells and tumor cells need metabolites. And so, there's a lot that we can do potentially targeting systemic metabolism to affect the efficacy of treatment. So another ongoing study that we have in the lab is to look at how exercise actually seems to improve outcomes in mice with breast cancer. So we found that treadmill exercise, running on the treadmill, both slows tumor growth by itself and also improves the effectiveness of immunotherapy against triple-negative breast cancer. And these are unpublished studies, but it's an ongoing project in the lab. And this is very exciting in particular because with this project, we're looking to try to figure out the mechanism by which this works. So it's been shown multiple times by many groups that exercise slows cancer growth, but we really don't know whether this is through effects on tumor metabolism, on immune cell metabolism, or the interplay between tumors and immune cells. And our hypothesis, although we're still working on it, is that it's really working by improving immune cell efficacy against the tumors. And the reason that this is very important is that, cancer treatment is tough, as you know very well, and not everybody is able to exercise. But if we can figure out the mechanism by which exercise improves outcomes, then there's the potential for developing, quote unquote, an exercise pill, some sort of pharmaceutical intervention that would recapitulate the effects of exercise without actually forcing people to do that exercise itself.
Yeah. I mean, certainly I think that where possible, exercise has a number of other benefits in terms of cardiovascular disease and other things. Whether it's your psychological well-being, your cardiovascular fitness, your gut motility, not to mention your cancer. So where possible, it would be wonderful for people to exercise. And it's wonderful that your research has shown that that's beneficial. It's certainly cost effective, but you're quite right. For people who can't, the idea of an exercise pill would be phenomenal. Kind of tying that back to the DCA story, have you found, like, on a molecular level that the impact of DCA is similar to exercise, or are you thinking that the exercise pill might be something other than DCA?
So it sort of depends on where we're looking at it. So we find that from a cardiometabolic health standpoint, DCA is similar to exercise. So DCA increases activity, it increases muscular strength, and it also increases motivation, very similar to what exercise will do. But that's a whole body level. And frankly, that's very beneficial. So cancer survivors, unfortunately, are at an increased risk of cardiovascular disease, so heart disease, even after they survive their cancer and they finish their treatments. We're still working on why this is, but it is a very clear signal. And exercise is certainly a potential intervention that can help these survivors to reduce that additional cardiovascular risk. It seems that DCA may actually have similar effects to potentially, and this is still ongoing work, but the data would predict that DCA may have similar effects to also reduce that increased cardiovascular risk. But if we're asking about the effects of DCA on a molecular level on the tumor itself, it appears not to have those same metabolic effects at the doses that we treat people and that we would treat animals with. So I guess, the question, as is often the case in science, the question is really, what is our question? And so if we're targeting cancer-related fatigue and cardiometabolic health, then absolutely. If we're targeting the tumor itself, maybe not.
So in our last minute or two, it sounds like there's a lot of really exciting things on the horizon. What are you most excited about in terms of future directions for your lab?
Yeah, so many things. I think, if you talk to me, I love science more than anything. And so there are so many exciting directions. I think, bringing these studies into people and talking with colleagues about potential next steps to actually translate this to the clinic would have to be the most exciting thing. We actually have a clinical trial that's just starting up very soon with another metabolism targeting drug. We don't have time to talk about that today, it seems, but there are a lot of sort of clear translational opportunities. And frankly, this is particularly exciting in the context of cancer because these metabolism interventions that we're talking about are so safe. They are safe in healthy people, in people with metabolic disease, much more so, frankly, than a lot of the approaches we use to treat cancer. And so it seems like there's a large amount of opportunity to really be able to develop metabolism targeting interventions that can help cancer patients both to slow tumor growth and also really improve their quality of life.
Dr. Rachel Perry is an assistant professor of medicine and endocrinology and of cellular and molecular physiology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.